So one of the real changes that are taking place in vascular surgery education is that we match medical students straight into vascular surgery. And so overnight, when you're a medical student, there's always somebody you can call. You're not making decisions. And overnight, you're on the front line and you get the calls. So one of the things that we do actually is bring in our interns to tell them what are the top 10 calls and things that you're going to have to deal with. And of course they all think it's ruptured aneurysms and cold legs. Well, it's none of those things. It's the real world they get called about is pain control, nausea, swollen leg. And so they have to be able to go through those things. They're really not specific for vascular surgery. They're specific for generally sick patients, and all of a sudden they're responsible for them. So we try to ease that transition by teaching them what, in reality, the on-the-ground problems are that they're going to deal with. A lot of people ask, why did we start this? Well, it was probably largely driven by the faculty, because all of a sudden they were getting calls. And again, the shift was that we were used to taking fully trained general surgeons who had done all of this stuff over the past 5 years and who now could really evaluate the patient. And now all of a sudden we're starting to get calls about same things. What do I do for abdominal pain? What do I do for nausea and vomiting? Those were scenarios that we weren't used to actually dealing with. And so we clearly realized that we needed a different approach to training and education than we'd had. We decided to start a pre-intern training course for our residents. Now we realized if we're going to go to this much trouble for our residents, why don't we just do something for most of the incoming residents? We start off with the basics. I trained in the UK. I learned anatomy. We wonder sometimes in the United States if anatomy is an elective subject in medical school. Well, we are vascular anatomists, so we need to make sure that they understand not just where the femoral artery is, but the branches, etc. So we teach them basic vascular anatomy. But we also see that anatomy using imaging, and so we teach them vascular anatomical imaging that they can help interpret. And then we teach them some of the early procedures that they need to be cognizant of and be competent in. And so realistically, what are they going to do? They're going to sew the skin closed. So we teach them how to suture. Okay? We teach them, how to put in IVs, how to do ultrasound guided access. And so we always say if you can learn how to use ultrasound, if they can learn how to use ultrasound to guide a central line insertion, if they can competently close up the skin and make it look good, they will get to do a lot more than they have. And so the message to the students is the more capable they are, the more they're going to get to do.